Hey folks, this is Dr. Desai. I'm here today with Sam Baer with Air One. Today we are going to introduce you guys to a new vasopressor that we're going to be carrying on our ambulances called Levophed or Norepinephrine. I know there's this idea amongst a lot of folks, oh, Levophed, that's leave them dead, Levophed, that's the last thing we ever want to use. That's actually contrary to what is current standard of care. Levophed is actually the vasopressor of choice in most etiologies of hypotension, and it's got much better outcomes than dopamine. So we're going to try to switch and get ourselves current and up to date by switching over to Levophed. So I'm going to let Sam take over, but I'm going to introduce you. This is Levophed, unlike our dopamine, is not pre-mixed. Okay, it's going to come in we're going to have make ready, get these small little packages that has everything you need to make a Levophed drip. Okay, and by the way, for those of you guys that are watching this, I have a studio audience here. It's our clinical education department, so there may be. I asked them to be in here so that way they can ask questions that some of you guys might have, and also if you have questions, either put a comment in under the video on YouTube or on Facebook, and we'll try to answer it for you, or just contact me directly and we'll try to get you an answer here. But I know this is something that's brand new, so please ask as many questions as possible. That way everyone can get educated on it. But I think we've kind of simplified this to where it'll be pretty self-explanatory. So all the ambulances will have this kit, which has everything we need. I'm going to open it up here so that way you guys can see what's inside of it. You point the camera down to the table here. So we open this up, okay? And the first thing you're going to see is this nice little instruction sheet, okay? It's basically got the step-by-step instructions of how to mix it and how to start it. It's got how we're going to implement it, okay? And then it's got some of our warnings right here that we'll talk about very quickly. The rest of the stuff inside of the bag, we're going to use a 60 drip tubing set, okay? And then there's going to be a smaller bag inside, and this has the actual medicine. It's got an 18 gauge to inject into the bag of saline. It's got a filter needle to draw it up. It's got a syringe for you to draw it up. It's got a label, because we're going to label our fluid bag. And then you got your little vial of Levophed. It comes in a vial, sometimes it's in an ampule, but this is Levophed. It is, I think I can't really see this, but it's 4 milligrams per milliliter, okay? So I'm going to turn it over to Sam here, and I'm going to let him explain and walk you through how we go about mixing this, making a drip out of it, and then how we actually use it. Sam.
Okay. All right. So with our kit, what you're going to want to do is you'll break out your norepinephrine kit, and you'll also need to grab a single bag of just your normal saline 1,000 ml bag. And so we'll get that out. The first thing we recommend doing is, just to avoid confusion for continuity of care, is we're going to take this label, your norepinephrine label, and you need to actually affix that to this bag so there's no confusion down the road and someone doesn't go infusing this there.
And give it as a bolus, okay?
Yes.
We never bolus norepinephrine, Levophed, or any other vasopressor for that matter, unless you're giving, epinephrine in a cardiac arrest. But this is not something that we're going to bolus. But we put the label on the bag, that way it's clearly marked and you know exactly what it's diluted to. Okay?
So after that, you can set that bag aside, and then you're going to prepare your medication. So you're going to have your vial of norepinephrine, and this is 4 milligrams in 4 milliliters, and we're going to be drawing up this entire vial. So,
No.
Okay, all right, so we'll go ahead, you'll break the vial open, and then you'll use your filter needle and 6cc syringe. Make sure you put that on there, drop all the medication. Once it's drawn up, you need to remove your green needle, take that off, and we're going to swap that with another needle. This is going to prevent any glass fragments that were caught in that needle to be removed there. And you'll grab your new needle, which will be an 18 gauge needle. You'll attach that to your syringe, and then we'll go ahead and inject it into the injection port on the bottom of the bag. Sometimes you'll see an injection port right here on the front of the bag, depending on which manufacturer it's coming from, but our current bags have it right here in a separate injection port, and obviously we'll follow the standard policy of swabbing that with an alcohol prep prior to injecting there. Once your medication is in there, it's going to be really important that you take this bag and you thoroughly mix it, because the last thing we want is to have 4 milligrams of Levophed infused in just our first cc's of our fluid. So you're going to vigorously shake this and have that all ready, and then we're going to go ahead and set that to the side. Once again, you're going to want to double check. This is probably just as important as you're checking your medication, is making sure that you have grabbed the 60 drip set. We're only using the 60 drip set for this administration, and this is going to provide an extra level of safety in the use of this medication.
And remember, this is all packaged in one little, plastic kit. So remember, this is all going to be all together in one little kit, other than the liter of normal saline, which I think everybody knows where that is.
Okay. We're going to break this one out. Once it's out, if you haven't used these 60 drip sets before, you're going to additionally be able to identify it as a 60 drip set by seeing, and I don't know if you'll be able to see it on the video, but there's a small needle looking port in here, in addition to what you'll normally see on your sets. So you should have a tiny needle little port in there, and otherwise it looks like standard IV tubing. So we'll get that, and that's going to go with there. We'll go ahead and just cover some of the safety aspects in giving this. So,
and then this kind of, currently it doesn't exist for our dopamine use either, but when we're giving any vasopressors through a peripheral access, these are probably guidelines that we should be following. Okay, so go ahead, Sam. I'll let you go ahead and finish what you were saying.
Okay. So running through our safety side of the sheet, you'll see it on this side, and we have kind of red and yellow. All of them are important, but some of these are just absolutely you've got to be on top of. And the yellow ones are probably somewhat more just cautions and documentation guidelines as well. So starting at the top, we never want to obtain a blood pressure on the same arm as your IV, and this is going to prevent that drug from getting concentrated in the arm. If that blows, you're just going to concentrate all that norepinephrine into a small compartment of the extremity. So we never want to do that, especially on a fragile vein, flowing something in there, more risk of rupturing that vessel. You're going to need to have a 20 gauge IV or larger, and that needs to be placed in the AC. We really want to prevent any extravasation down to that extremity. The studies basically show that you have a higher risk of losing an IV and causing complications if it's anything distal to that AC. And ideally, these are put through central lines, and this is really only a temporizing measure. As we get through, and I'm going to show you actually dripping this in, we're going to want to make sure that we never allow this medication to free flow. We all understand that any type of gravity chamber is 100% dependent on where the patient's arm is, how much it's bent, how high your bag of IV solution is. So no matter what rate you think you're going at, you should always be able to see physical drips coming from that chamber. If you can't see physical drips, you're running it too fast, and that needs to be backed off. And then you're going to want to make sure that patient's arm stays straight at all times, because if we're throwing this in the AC, we don't want to kink off that line, dislodge our IV, and potentially cause complications there with this patient. Some charting things that we're going to have to be really aware of is we need to make sure we're obtaining and charting vital signs Q5 minutes. Anyone on a vasopressor, no matter if you think they're stable or unstable, if you're on a vasopressor, you need to be getting 5-minute vitals, and those need to be documented in your chart.
And the other thing is you also need to be titrating the vasopressor accordingly. So if you have someone that you're starting Levophed, or even for this matter, even for dopamine, if you got somebody that's on a drip and you start it and their blood pressure is still 80s, okay, we probably need to titrate up on the vasopressor dose. So keep that in mind. Document, chart your vitals, but then also react to what you're seeing. If you start somebody on Levophed and their blood pressure is now 150 systolic, okay, we probably need to back off on the Levophed. So keep that in mind, okay? You look for the results that you're looking for and keep the treatment going accordingly. The other thing, you want to monitor and document that your IV is patent. Okay, these are vasopressors. Okay, when we're giving it through a peripheral line, you never want your IV access to infiltrate, or you never want vasopressors to be infusing into, you know, in tissue. Okay, you will cause necrosis. You will cause significant damage to a person. So make sure you're checking the IV patency to make sure it hasn't infiltrated, to make sure everything is flowing. You need to monitor, and we need to be documenting this. Okay, very important, because if you didn't document it, that means you didn't do it. So we have to get into the habit of documenting this in addition to monitoring it. Okay, so every 15 minutes we need to monitor and document the IV patency and make sure there are no signs of infiltration. And then lastly, if there are any signs of IV infiltration, or looks like IV access is malfunctioning, not working properly, stop the infusion immediately. Make sure you report this to the receiving facility and let them know. Okay, and above all, anytime you start a vasopressor on a patient, make sure you show them this is Levophed, I started this, and give a good report on what you did and why you did it. Okay, so now I'm gonna let Sam talk about. We've got the Levophed in the bag. We've got a great IV access in the AC fossa. We've got a good 18 gauge. Patient's blood pressure is 75. So we're gonna go ahead and start Levophed, and he's going to show you a little bit about how you determine what dose it is. And this little sheet right here, let me see if I can get it to show. It shows you the dosing chart. Okay, we count the drips to determine how much we're giving. Given the dilution, we're going to start at 4 mics per minute, and that's 1 drop per second. Okay, 60 drops in a minute. Okay, so that makes it pretty easy to count and keep up with what you're doing here. Alrighty, and then so this will be in all of the Levophed packages. This little chart right here. We'll be doing a dosing of starting at 4 mics up to 16 mics. Okay, if you're not seeing results by then, I'm not sure we want to go any higher, because it may become difficult to count those drops without just opening up the bag of fluid. I mean, 4 drops per second is pretty quick. That's pretty rapid. So I don't think we'll need to, go that high. I think in most instances, our transport, we'll get to our destination, or, we'll probably see results with a pretty low dose. Levophed is pretty effective. But that little chart will be your guidance on, okay, how are we starting this? And it's basically drop counting. So I'm going to let him go ahead and show you, just kind of demonstrate what it looks like.
Okay, so we're going to use standard aseptic technique. Remove the spike from our tubing. We'll insert that. Prime as usual. And Dr. Sy, if you don't mind just hanging on to that bag. I'm going to fill this chamber up. And we'll flush our IV tubing here.
And remember, this is all in the kit. This is the 60 drop tubing set. Okay, so make sure you don't grab any other tubing set. Make sure you use what's going to be packaged within the kits. Okay.
And you're going to notice that it's going to take a little bit longer to prime with this IV tubing. If it primes exceedingly fast, you may want to double check and make sure you have the right IV set.
Yeah.
Once we flushed all our bubbles out, a couple more in there. All right. So we'll try to get you zoomed in right on that. We can get the bag right up by the video camera. All right. And then we'll just bring that drip chamber right nice and close and see if we can see it there. So obviously starting off, and I don't know if we'll be able to try to get it black on the background here. All right. There we go. And so we're going for a drip a second. And it won't have, you probably won't be able to incredibly precise, but you'll play around with it. Kind of 2 at a time there. Kind sets of 2 there.
Mm-hmm.
There we go.
There we go. Kind of difficult, but
Yeah.
I think we're not dealing with pumps here, so you've got to do the best you can here. It's kind of similar to how we were doing dopamine, right? You try to get it, but you want to get it to 1 drop a minute. That's how you're about 4 mics per minute right there. Okay, so this kind of give you an idea. Okay, if we need to go up on this, we need to increase the dosing. That little chart lets you know. Okay, this is roughly where I'm at. So.
And the nice thing about mixing it in this dilution is you have a pretty good margin, so changing by a drop or 2 isn't going to be, over a minute, isn't going to be a huge change there. To double your dose, you're having to double your drops there, so you'd have to go from 60 to 120 just to move up by 4 mics. So you have a pretty good safe margin there, and then once it kind of gets set in the ambulance, you should be able to kind of just adjust it to their blood pressure and go from there.
Yeah. And remember, like anything, you won't see immediately their blood pressure is going to jump up. You're going to see a few minutes before it actually starts going up. So, if you started at 1 drop per second, 4 mics per minute, and 5 minutes have gone by, you haven't seen any results yet, don't just jump the gun and start, increasing your rate here. Give it a few minutes, give it a few minutes before you start increasing it. If 10 minutes have gone by, 15 minutes gone by, you're still not seeing any results, okay, go ahead and increase it. And you want to increase it incrementally, right? You don't go from starting it at 4 mics and jump straight to 16. Go up slowly on it. Go from 4 to go up to 6, go up to 8. And then you can kind of see it, and make sure you give enough time for it to work. Okay, it's not an immediate effect like everything. So make sure you're giving it enough time. These are we have to be very careful with these medications. Giving too much all at once can cause some problems. So and that goes with any vasopressors. Okay. So I think we get the gist of that. So that's basically Levophed and how you implement it. Okay, I've got a studio audience here today. So what kind of questions do you guys have regarding all this?
What's our target blood pressure goal?
So good question, and that's something that is written in here. You want to titrate for a systolic blood pressure of 90 millimeters of mercury. Okay. Ideally, or remember, everyone is different, right? So if you have an 85-year-old patient and they say, yeah, my blood pressure is normally 88 to 90, don't start them on Levophed, obviously. But if you got somebody who's usually 120, 130s, or hypertensive for that matter, make sure you want to titrate Levophed for a systolic blood pressure of 90. Okay. What else?
For crews out there, what's going to be the indications and contraindications of this drug?
So Levophed, it's a vasopressor, right? So if you have a patient, and this is something else that we're going to be introducing here, is we're going to start doing a little protocol on identifying patients with potential sepsis. Okay, but indications for vasopressors are you have a hypotensive patient. Okay, they're in shock, and you're giving them fluids and you're not getting their blood pressure up. That's when you're going to start Levophed, whether it's septic shock, whether it's hypovolemia. It's pretty much the exact same as what you would use your dopamine for. And I understand this is not something that we're going to be doing very often. I know we're not starting a whole bunch of dopamine on folks either, but we're going to carry a vasopressor. We're going to use a vasopressor. We need to use the vasopressor of choice, which currently, based on current guidelines and standards, is actually norepinephrine, no longer dopamine.
You've got a pretty ill patient and you are going to start fluids, but you anticipate that fluids aren't going to do anything. What kind of guidelines do you recommend to maybe start preparing for the Levophed drip, or do we wait till we get a liter of fluid in, or do we just, if we're going to anticipate it, let's go ahead and get the drip started, and then as the liter of fluid's maybe not doing what we want it to do, then we hook them up to the Levophed.
Sure. So I usually, I'll usually give a fluid challenge first, right? Typically, in the hospital setting, we usually do up to a 30 milliliter per kilogram fluid challenge. Okay, that's a lot of fluid for a lot of people. And I'm gonna do a video shortly hereafter on a sepsis protocol, because your septic patients are the ones that have huge, fluid requirements, and a lot of times they'll need vasopressors. But in our protocol, I would say, hey, let's do at least 1,000 milliliters of fluid, since we don't really have a way of assessing if we're putting them into overload or not, and sometimes you won't know that quickly. 1,000 milliliters of fluid bolus is what we're going with for now. And after that, if you have not reached your destination and they still have hypotension and you've got a pretty good distance left to go, then I think at that point we can continue fluids, but maybe worthwhile to maybe start a Levophed drip at 4 mics and help support their pressure. Good questions.
So just like the other medications that we carry, this is going to be in the medication in our drug bag as opposed to being carried into a residence.
This will not be in your drug bag, so this is going to stay in our the drug box that's in the ambulance.
Okay.
Because, like I said, it's going to be within this prepackaged plastic pouch that has all your tools and everything. So not something that you're going to be taking into a residence or anywhere. This is something that, okay, you obviously you want to start if you got them in the ambulance and you've got a ways to go and your initial fluid challenge has not worked. That's when you're going to use this. So you should rarely ever have to take this out and take it with you anywhere, Not something that you're going to use when you're doing CPR on a patient or anything like that.
Dr. Desai, do you see any need for any other notes on the label? If they just apply the label to the bag, no need to note the time.
That's good. If they do noting the time, and hopefully you're charting this, you should be, because like I said, that's part of our protocol is going to be, you have to document your Levophed effusions, and you're going to be monitoring your IV patency. So yeah, you want to definitely document a start time. Okay, I mean, I know we're not doing a bunch of 6-hour transports or anything like that. Hopefully, if you are, you're coming from another facility and they've got you on a pump and everything. But yeah, you certainly want to document if you started Levophed, when you started it, and let's say you stopped it before you got to the destination, put a stop time too. But I think within our system, we don't really do very many transports that are that long that you're going to start something and boy, you fixed them up because your distance was so long that you ended up having to stop it, But yeah, absolutely document the fact that you started it and what time you started it.
Would it help the hospital staff if it was on the label?
Absolutely.
Start time?
Yes, absolutely. Because, if we need to document it in our charting, but of course the hospital system's not going to have access to that. So I think putting a time on the bag, great idea.
So we're talking about IVs. What about, if this is a hypotensive patient that we can't get an IV on, but we can get an intraosseous on? Can we still use this intraosseously?
Excellent question. That was something we were looking at. I don't know if we're ready to do that yet. Just because when we're giving this, we don't want it leaking into soft tissue, And I know sometimes interosseous, it's pretty easy to know for sure if you're in or not, but that's probably something that I'm gonna revisit on, depending on how easy is it to truly know if you're intraosseous or not, right? Because otherwise this can cause tissue destruction if it's not. That's why I prefer it for now. It certainly is usable intraosseous, but I think right now it's a lot easier to confirm that we're intravenous sometimes than we are intraosseous. So in the scenario you got a hypotensive patient, you can't get a 20 gauge or larger in the AC, I would say we're not starting vasopressors, do fluids, and get them to a higher level of care. Because our risk of causing damage to those folks that we are not absolutely 100% perfect on, we can cause some harm. So what you can do in that scenario, if you do have a long transport, you know, and all you have is a 22 in the hand, okay, get a fluid bolus going, and then as you get some volume in them, sometimes, you know, they have some access that pops up. Recheck the patient and see, okay, if you see something that looks like you might be able to get it, make an attempt and see if you can get a 20 or 18 in the AC. And at that point, if you are, and the other thing is, if you do have access, you're going to test that access with a 10 cc saline flush to make sure it's patent before we start Levophed. Okay. And I think these are details. I looked at our protocol. Currently for dopamine, we don't have these details, but even until we get Levopheds on the trucks, which is hopefully going to be pretty quickly, hopefully by the end of this month, if anybody is going to start dopamine, these same things need to apply to dopamine because it's the exact same thing. Dopamine in tissue is also very not good. So if anybody's going to use dopamine, we need to be doing the same thing for that as well.
So there's obviously a lot of concerns about drug shortages and discontinuations and things like that. Just specifically speaking of the size bag of fluid,
Yes.
the other size bag of fluid that we carry is a 250.
Yes.
Is that an option, or?
That is an option, and that's the standard. Usually it is. It's mixed in a 250 cc bag. However, since we have to operate without pumps, the dilution is not as easy when you're in a 250 cc bag and you're having to count the drips. And that's why we're going to do it in a liter bag, just because it makes it a whole lot easier to do the drips. As you can see, you know, this is a whole lot easier to count. If it was if it was in the 250 cc bag, it would be a whole lot. I mean, you see how hard it is just to get 1 drip per second, so it would be a whole lot harder to get that diluted down to where we can do 1 drop per second is 4 mics, you know. So yeah. Hopefully we won't have that, but if we do, we'll cross that bridge. But for now, I think IV fluids are back in action, and there's no longer a shortage from what I understand.
So something that we're always taught is what we were taught was this was the less preferred drug over dopamine, but it seems that it's not the case. Can you speak to some of the specific advantages of Levophed over dopamine?
So Levophed, and this has all come about from a lot of the sepsis literature. You know, sepsis is a very big thing. That's why we're going to be putting out a protocol as well that's going to follow up on this. But it's been shown dopamine is not as, I guess, outcomes are much better with Levophed. Dopamine, and I'm going to do a talk on this a little bit later this month that kind of goes through all the different vasopressors and why we use and what. Dopamine does have its place, but initial Levophed has become the vasopressor of choice. And you'll see it's a little bit cleaner than dopamine. Dopamine has a lot of effects on a lot of different parts of a lot of different organs. You know, you might get an increase in your blood pressure, but then you also see your heart rate jump up to 140. You don't need that, right? So it's kind of some of the effects of dopamine are counter effective to itself. And I'm gonna do a talk that kind of goes more into details about that. Okay. Well, I think that's all the questions everybody here has. Everybody is going to be required to watch this because this is a new medication we're introducing to our trucks, and there's going to be a test on ninth brain that everyone needs to take regarding Levophed and the use. And it's basically going to be based off of this video. There's not going to be anything tricky or anything about it, but we want everybody to know how to use it, when to use it, and if we are going to use it, we need to be using it properly, as goes for anything. So if you guys have any questions or concerns, either comment below or contact me directly via email or come talk to me, and make sure you understand everything about how to use it and when to use it. Okay, we'll talk to you next time.